We'll get started today with Skip Rizzo. You've sort of heard a lot about Skip already, so I'm not going to do a whole grand introduction other than to say he's been doing this for a long, long time, based out of USC, and has been really focused on a lot of areas, but trying to understand post-traumatic stress is one particular area where he's done a lot of his work with Gulf War veterans who have had sort of war trauma, psychological, physical war trauma, and using virtual reality to desensitize and to engage these patients in different ways. That's just one small part of the breadth and depth of virtual reality technologies that he's developed. So today he's going to share with us the latest and greatest, and I'll get off the stage and introduce Skip Rizzo. Thank you so much, Skip, for being with us today.
Mic working? There we go. First off, Brennan, you've done a kick-ass job getting this thing together. I mean, really, a round of applause. It's a hard act to follow all the talks yesterday, but I'm going to try to do my best here and start off. I'm going to address the issue of bench to bedside in the course of describing VR across a wide range of fields, talking about the theory, the extant research, the pragmatics, the feasibility. And so the talk will be broken into three parts. I'll start off right now with a discussion of what I see as the key ingredients for VR in the clinical practice area. First off, just mentioned I'm located at the USC Institute for Creative Technologies here in Los Angeles. And our lab has been around since 1996, back when VR was in the first heyday, the first hype cycle, soon to, actually, 96 was probably the beginning of the nuclear winter of virtual reality, where all the hype and excitement was there, but the technology kind of sucked. It was, the enabling technologies were not mature, and consequently, it was viewed as a failed technology from 96 onward, and that's changed, of course, recently. But anyway, our work is focused on psych, cognitive, motor applications, and work with virtual humans. So this is a little taste of some of the work. This is virtual Iraq, Afghanistan. You'll see more of this later, so I'm going to jump ahead. We'll talk about that later. That's what it looked like 10 years ago. So give you a little bit of an idea of the improvement in graphics. In this use case, we basically took an exposure therapy treatment environment and modified it to deliver cognitive testing in an immersive environment. So tests of attention, memory, executive function. We don't just do military work, of course. This is from 1997, a mental rotation assessment and training system. We did a lot of visual spatial stuff. And back when that was done, it took about $300,000 worth of equipment. Now, for about $3,000, if you can find an old stereo TV, you can do the same thing. So the cost to deliver this stuff has gone down dramatically. This is from 2003, a virtual classroom that we developed for the Psychological Corporation from our previous work in '99. It was going to be a product, but everybody loved it. It was a good tool for testing attention in kids in an ecologically relevant environment with distractions that were programmable. And when we did focus groups after we built it, we already had a lot of good data with it. People loved it. But when you asked them that last question, would you be willing to spend $8,000 to $10,000 on a computer and the software to run this, then everybody kind of got a little hesitant. And so it never made it as a product back then. It became a research tool, and I'll talk about this a little bit later. But it's getting a second life and being updated now because now you can do something like this on a Samsung Gear headset. And one of my cases here for the ascendance of clinical VR is when a clinician can pull a mobile phone or standalone headset out of their desk drawer and hand it to a client. Now you're on the road to wide-scale adoption. This is work we did prior to the Microsoft Kinect. This is with a PrimeSense camera, but 3D body capture for physical therapy, occupational therapy applications, try to make very boring, repetitive, frustrating activities after a stroke or TBI fun and engaging. We also took the same technology working with the Cerebral Palsy Foundation, and basically their request was make it so children with severe motor impairments can play video games. So we took a Kinect, and basically this movement, this little girl's movement here, was the only movement she had real good volitional control over, so that became the interface for playing the game. She couldn't operate a gamepad or anything. First time she ever played a video game. And so we've continued working in this area with more complex games. Finally, the one area that we focused a lot on, I won't have time to go into it in detail later, but just pop up a couple clips, is our development of artificially intelligent virtual human characters. And in one case, as you'll see next, virtual patients for training novice clinicians. This is, I think, from 2012, a project we did with the USC School of Social Work with a social worker that you'll see here.
Good afternoon, Sergeant Castilla. What brings you in today?
Well, my wife told me she thought I should talk to someone. She's been pretty concerned about me since a soldier suicided on base last week.
Did you happen to know the soldier?
Yes. He wasn't a friend, but I met the Marine once or twice. He seemed normal at the time. I guess I'm afraid I might end up like him.
Do you have any plans to hurt yourself?
No. It certainly crossed my mind, especially lately. I just need it all to stop. Sometimes I can't handle it.
So, I like to encapsulate that by saying it gives novice clinicians a chance to screw up a bunch with a virtual patient before they get their hands on a live one. And I think anybody in the clinical field knows that might be a good thing. Finally, taking that same technology but putting it in an online format. This is one we did for the Army as a tool for breaking down barriers to care with service members, veterans, and their family. They could go online and talk to this guy privately and anonymously about PTSD, ask questions. The character would ask screening questions that were in the midst of a conversation. At some point, he might say, hey, looks like you're having some trouble. Why don't I pull up the National Center for PTSD site, and you can punch in your zip code, and a list of providers in your area will pop up. So it was not about replacing good clinical care, but inching someone a toe in the water towards maybe seeking help they can benefit from. I'll just let him introduce himself real quick here.
Well, I'm not a real person, if that's what you're asking. But I'm based on the personality and experiences of real soldiers and Marines. I'm still just a piece of software, but I'm getting better all the time. So hopefully I can be a helpful piece of software to talk to.
Okay, so with that, my driving metaphor for these applications is aviation simulation. So just as an aircraft simulator can serve to test and train piloting ability under a range of controllable conditions, we can test, train, teach, and treat human function similarly in virtual environments. And in some sense, if you're a student of psychology, it's the ultimate Skinner box, controlled stimulus environment. Since 1994, when VR first started to get its clinical traction, it was mainly used for exposure therapy for specific phobias. Since that time, there's a short list of areas where VR has been applied clinically, either as a tool for diagnosis, intervention, or scientific research in these areas. A lot of reasons why VR makes sense in these areas. I'm not going to go through all these assets, but depending on the needs of the clinical application, some of these assets make a lot of sense for a VR application. If you're interested in more on this, send me an email. This paper just came out in December, and it goes through a lot of the assets and covers a lot of things I'll talk about today. But a shorthand way of looking at where VR has power clinically is this little model: expose, distract, motivate, measure, and engage. And we'll step through these really quickly. We talk about exposure, exposing people to things they fear. And this is exposure therapy, the concept of helping a person to confront things that they fear or confront things that they've been traumatized by, to confront and process difficult emotional memories in a safe environment, falls in with this theoretical basis of behavioral theory of extinction learning and graduated exposure and so on. So it's a theoretically informed approach that we know from years of research has value, and it matches well to what we can do with VR exposure. And over the years, people have addressed specific phobias and so forth, such as these. So if in 1997 you had claustrophobia and you happened to be in Spain, you could go to Christine Batella's lab and she'd put you in this room and then close the door on you and then gradually move the wall in on you. And they built a whole variety of these kind of environments. Fear of heights is where the science started to come into play. People started studying this in clinical trials. And the interesting thing was in 1994, Larry Hodges and Barbara Rothbaum used this scenario, and nobody would mistake this for the real thing, but people with phobias sure enough did. And as we all know, when we tried the plank demo or the pit demo and all that, even if you don't have a phobia, your brain reacts as if it's the real thing. Frontal lobes are saying, I'm on a solid floor here, no problem. Amygdala, limbic system, other areas, it's saying, whoa, be careful. So that even if it was graphically impoverished, like it's not any longer, we could get good clinical benefits. And of course, it's gotten better, and these kind of scenarios are routinely deliverable on a mobile phone-enabled VR headset. And as Walter showed this one yesterday, we both agree this is one of the cooler apps where it pits your fear of heights against your love of kitty cats. And what they need to do is have a little dog there for people that aren't such cat people like myself. I like cats. But anyway, fear of flying, of course, 1997, that's what it looked like. 99, 2000, 2005, people down in San Diego actually modeled the United Terminal at the airport there. 2017, this is, standard stuff that you can get anywhere. Companies are popping up all over the place making SciAS produce this to run in a mobile-enabled headset. Really good computer graphics that, I think really raised the bar in terms of promoting accessibility and realism and driving us towards hopefully wider positive adoption of the technology. As far as the research goes, our group and another group in 2008 did a meta-analysis on anxiety disorders, came to the same conclusion. VR outperformed the imaginal exposure approach and was as good as in vivo exposure when those conditions were available. The results updated in 2012, and later in 2015 in a meta-analysis, they documented that what happens in VR actually matters in the real world, that people going through these kinds of exposure approaches actually do get better in the real world and fly on airplanes or handle spiders or, are able to go up a glass elevator at the Bonaventure Hotel. So post-traumatic stress disorder falls into the same sort of treatment approach. And at first it sounds like torture, but basically it's helping a patient to confront and process difficult emotional memories in a safe environment. They're not passive, they're narrating their experience, and the clinician can control all the elements that are in the simulation in real time from a Wizard of Oz control panel. So put a user in any one of these types of scenarios, you can adjust the time of day, the sound effects, how many people are in the environment, and help pace the client towards this approach to confront and process. And we're not the first people to do this. Barbara Rothbaum with Virtual Vietnam, some folks up in Buffalo with Driving, Joanne DeFede and Hunter Hoffman with Virtual World Trade Center, and Hunter Hoffman also worked in a group in Israel in a bus bombing scenario. Our work is Brave Mind, 14 unique worlds that model after Iraq and Afghanistan, different contexts. Clinician can make all these things that you see happen in the world, whether it's a helicopter going by or a car bomb going off, all to match the patient's experience.
By going through it there, it's not going through my head at night when I'm trying to sleep or when I'm with my wife, when times when I don't want it to come up and me start thinking about it. Traumatic things are not normal. You cannot handle the things that we've seen and done. And this is a tool that has helped me out tremendously.
Reliving the worst moments of his life has helped him to move on with his life.
I'm probably about 80% of who I was before I left, but I think that's pretty good after seeing and doing the things that we've done.
For Nightline, this is Dan Harris.
So,
in Atlanta.
There we go. So what about the data? Well, very first trial, first 20 treatment completers, safety feasibility trial, we got good results. This is the individual data, 16 of 20 no longer met PTS criteria at the end of treatment, 4 did not benefit. Follow-on study up at Fort Lewis, same pattern, same clinical and statistically significant reduction in PTSD. A really impressive study published recently in the Journal of Anxiety Disorders, Deborah Bidell, what she did was to do intensive treatment. 3 weeks, you move to Orlando for 3 weeks. In the morning, you do VR. In the afternoon, a mix of cognitive behavioral therapies, anger management, substance use, group therapy, and so forth. And got very little dropout. It was like 7% dropout, which is really good for this kind of treatment, and good clinical outcomes. And admittedly, there's a bias here. Anybody, there's a motivational aspect here. Anybody willing to move to Orlando for 3 weeks has to be motivated to work on their PTSD. But maybe it also says the old model of, once a week for 10 weeks might not be the best way. I mean, these are really good results. Barbara Rothbaum, similarly, showing progressive changes that were maintained 6 months and 1 year follow-up. And also in that study, they showed beyond self-report data, physiological data, showing reduced reactivity when people were in standardized VR simulations, and additionally, changes in cortisol reactivity over time. So starting to go beyond self-report and trying to get objective measures. More recently, we've evolved a sexual trauma system. We started off by modifying some of the areas in the Afghan content, but we found out from interviews with victims of sexual assault in the military, most of it doesn't happen in the trenches of Afghanistan. It's happening around bases, stateside. So we built a bunch of civilian contexts. We're not building virtual sexual assaults. We're just building the context in which these things are commonly reported to have occurred. And again, you always start off with a small sample to test to make sure you're not going to hurt anybody. And that data was positive. 15 people recruited, 3 dropped out right after their initial assessment, so they never went into VR, and 1 dropped out in the middle. But the 11 that completed, this is their data. Also, we're just starting to look at the psychophys data, but just initially we can see changes in heart rate when people go into a standardized simulation pre and post-treatment across a 3-minute period within that simulation. So showing that we can benefit beyond just self-report. This is a series of studies that have recently been published using the same 3-minute standardized simulation, looking at physiological and cortisol reactivity when people are in these environments to maybe develop a predictive model to develop a diagnostic assessment for PTSD. Self-report is often unreliable in this area. And finally, Mike Roy, moving into looking at what's going on in the brain when people go through this treatment, did pre-post exposure therapy in VR and found changes in brain activation in the predicted direction based on the theory. So again, starting to move beyond just the treatment and the self-report, but as important, we got to look at breaking down barriers to care. Maybe this is a form of treatment that may appeal to a digital generation of service members. And a recently completed randomized control trial that we just finished with Joanne DeFede, when people were given informed consent and told about you're going to either get VR exposure or traditional imaginal, but you're going to be randomized, so there's no choice here. But if you had a choice, what would you pick? 75% picked VR. So that's, positive guide for the future, and our work now is starting to move towards civilian application. We have a project with the RAND Corporation looking at LA police, possibilities there. Google has a project now, a couple of other groups around the country focusing on police, firefighters, and first responders, in addition to sexual assault. So distract. All right, I'm going to fly through this because we've already heard a lot about it, in the areas of pain management and so on. Again, starting off with theory, it's theoretically informed. We know that attention is key to the perception of pain. If you divert attention away from the experience of the pain, you see a perception change. So, with all these areas in VR, we're seeing that if you start from a good informed theoretical base about what works in the real world as your start point, you might have a better shot enhancing that effect by leveraging the virtual world. And Hunter Hoffman showed this back in 99, 2000, showing changes, comparing VR with playing a video game. and that the effect lasted over time. And these findings have pretty much been replicated over the years in this kind of burn wound pain, and as well with experimentally induced pain. That's your brain on VR, your brain off VR, activation levels when people have a hot poker or thermistor put on their foot to see how well they can withstand pain. If we look back in history, Hunter Hoffman actually used Spider World, a spider phobia scenario, as the distracting content in some of his first studies. So it was just anything, something. Later on, developed Snow World. The good news is there's tons of this stuff out. You can give users choice now. There's a lot of content, as Brennan knows from the work he's done with Applied VR and other groups, where tons of content out there. And whether it's off-the-shelf content or specialized content like this, it's developed specifically for pain management. The stuff is there. Also, a little pitch for my buddy Ben Obrata, the underwater VR headset. This might be of use in some cases with hydrotherapy, but this dolphin swim content, of course, is available to run in the gear and can be used terrestrially. But it's very cool to do this because you're floating in the water, and it's another element of immersion. It's really cool. And the good news for everybody, this was a demo that I did at South by Southwest up on the rooftop pool at the JW Marriott a couple weeks ago. But the good news is later tonight, if you're so inclined, you can drive out to my house. And we have our pool heated up. It's about 79 right now, but it will be at 85 by the time we get there. And as the sign says, VR, warm water, and cold beer. So, and, underwater dolphin experience. Anyway, and I also want to mention this because a lot of times old research doesn't get dug up. And so Sue Snyder, this work with chemotherapy, and I'm just going to let this video play here.
This is virtual reality. Today, 27-year-old breast cancer patient Cindy Worthing will solve a mystery on the Titanic during her treatment.
No passengers. That means you.
And from that work, she collected a lot of data, documented the value of this in patient engagement and interest in this area. But somebody mentioned yesterday about time shrinking. Excuse me here. And she found that effect statistically, that people's perception of time goes down when they're in this kind of an experience. And here's a couple of people talking about it.
They asked me at the end of after the treatment, how long they thought I was on doing the virtual reality. And I said, about 20 minutes, and really it had been an hour.
Couldn't believe it when it was finished, because I didn't get to complete the game.
So, how many people want to stay in chemo to finish up the game? And of course, people are doing this now. I have a bone to pick with this particular group. They're doing great work, but they make claims on their website to be the first. And honestly, there's not a lot of firsts left in VR. You don't need to tout it. But anyway, I'm not going to let this play. We all know what it's going to show, and I need to get moving on. Jose Masso in Mexico, using it during surgery. That guy is still getting anesthesia. The VR is just to make the experience a little more comfortable. So motivate and measure, I've collapsed these two together in the interest of time, because motivating people to do rehab is, at the same time, you're measuring performance in these game-based things. So we know that VR meets the needs of good rehab tasks. The criteria for good rehab that's being listed here, VR is ideally suited to be able to deliver on that. As well, Mike Merznick's model of neuroplasticity, attention, novelty, and reward, driving neurotransmitter systems that may underlie neuroplasticity. Well, attention, novelty, and reward, those are elements of good, well-designed games. And we know people will work out more if they're given something to engage in as part of the workout. So it's motivating. People have done a lot of stuff with high-end robotics. You have to, have a little bit of resources to do this stuff. But the data is there. It's showing positive gains with repeated practice. Getting people to do sufficient trials of rehab is the goal here. I mean, it's not magic here. We're just trying to motivate people to do more of it. And, research of Rob Reiner's group showing advantages over usual care. Our work since 2001 in this area was trying to use cheap and dirty interfaces. Somebody talked about respiratory therapy yesterday. The upper right, I have a digital spirometer. This is like 2005 to try to build a game around teaching breathing and practicing breathing. But, we did a lot of things. We built our own tracking system with an LED system and a webcam that would track user movement. But when the Kinect came out, that really changed things because now you had a low-cost device to track user movement, and it really changed things up. And we see a lot of companies now developing systems around this and other sensors as well, because now the Kinect isn't being made anymore, but there's other sensors to fill in the gap. And we're actually working a lot with the Leap Motion sensor attached to the front of a headset where your hands in first person can interact with digital content for upper extremity rehab, as you see here in these kinds of applications. And if anybody's interested in working with us on this, we're going to make these available. We've got about 15 different games. I've got to jump ahead here. Basically 2007, limited but sufficiently encouraging results. 2011, potentially useful technology can be combined with conventional rehab. Meta-analysis in 2016, equivalent to traditional therapies. And finally, 2017, somebody makes the claim more effective. I'm on the fence either way, but as long as it's as good, if we can motivate people to do more of it, that's where we're going to see the benefit. Measurement, virtual classroom, controlled stimulus environment. Child has to pay attention to what they see on the board and resist looking at distractions around the room. I'm going to just show some quick data with this. We can clearly differentiate kids on the ADHD spectrum, if you will, from healthy controls. We can measure motor movement, head turning, and so forth. That's over a 10-minute trial. The red line is the head movement of a child with ADHD across the whole trial. If you look close, there's a green line in there. That's a randomly selected healthy control. And you see the differences, but we can also render it in a way that's really intuitively graspable. So that same data is planted on these little heads. The kids are looking at the blackboard 24 seconds in, now 53 seconds in. The ADHD kid's doing well. The neurotypical may look away, but he gets back on task. But now we're going to jump to 5 minutes, and now you start to see over time the distractibility kick in the ADHD kid. He starts looking around at all these stimuli that he's already seen a couple times, as you see here. And we'll jump to the exorcist clip here, 7 minutes. That's actual movement. And now you're going to see he's going to spot a paper airplane flying around the room. Here we go. And he's going to follow it. Now he's going to look up at the ceiling. And so you get a real clear, intuitive grasp of the impact of distraction on these kids. And you get the data. You can specifically tell if the child's looking out the window and missing a target or looking at the target and missing it. That's a loss of focus versus a distractibility issue. You can't get that with a traditional paper and pencil or flat screen test. Anyway, a lot of research has been done, and the system's been updated now, going through trials actually in Taiwan. So finally, engage. We can engage people, of course, in exotic worlds. In pain management, that's part of the game. We can do that. But we also know VR engages people. Maybe not for hours and hours, but there's plenty of games out there that show that people like playing these things in VR. You can captivate attention. I just want to mention engagement in terms of work with virtual humans. So these are some old school virtual humans right here, but the field is getting better. Characters are more credible. You can engage them in natural language dialogue with voice recognition and have credible interactions. If you look back, just one use case, autism, This was 2002. Even these primitive characters, which might be well tuned for folks on the autism spectrum, not too overwhelming, this application actually showed value for teaching social skills in a variety of contexts. We've taken it now and address right now an application. It's out at about 200 sites now for job interview training. So you've got 6 different characters, a variety of different backdrops, and each character can be set at a different 3 different personality levels, like soft touch.
I'm glad you're here. In a minute, we'll get into some questions about the job. But before we do, why don't you just tell me about yourself?
Or you can make her cranky, or you can pick a different character, but...
This is an entry-level position. I guarantee there will be things you won't like about this job. That said, what's the most important thing you think you're looking for in a job?
And a happy user.
It's a good program, and it teaches you how to do an interview, and it teaches you how to be in an interview situation with another person.
And did you see your performance improve? Did you get better?
I get better every single time I do it. I get better.
And that's data from a recently published study showing progressive improvements with practice and changes in live interview ratings by vocational counselors. Now it's being used by veterans, and we're working with a prison population in Florida. So generally, in all these areas, I think we can make a strong case. It's theoretically informed. The research is good. We still got a ways to go. We're at the very beginning of this field. You know, psychology's been around as a science, 125, 150 years, you know, looking at human behavior and interaction in the real world. Well, you know, human behavior and interaction in the virtual world needs, you know, a good bit of study still. So still got a long way to go, but it's all encouraging. We got low-cost, high-fidelity systems and a very passionate development community. So things are good. I would say that one of the areas we need to focus on is, can we break down barriers to care? Aside from the efficacy stuff, can we make people more aware of this? Can we improve the anticipated benefit, the availability of well-trained providers trained with VR, improve accessibility, all the 7 A's. And my paper will go into these in detail if you want to get that. So to close, we got a bright future ahead. You know, sometimes understanding the future is made easier by looking at the past. You know, we've seen things in the past. In the 90s, that was the vision, you know, get into the game, get into the computer. The reality was in the 90s, it wasn't quite there. But something happened around 2011, 12. This guy, Palmer Luckey, was working in our lab, working with Mark Bolus, and then working with the PTSD project for a while. Did a Kickstarter, raised money, formed Oculus, and sold it for $3 billion, and then now he's no longer doing VR. But anyway, he drove, you know, that was a pivotal moment because it drove all this development. Low-cost systems, the ability to have spherical video like this as a commodity tool, commodity headsets, you know, a bright future, also driving interface devices, because we can't neglect the idea that users should be able to interact in a virtual environment in a credible and useful and usable fashion. So, you know, this is an area that's evolving. You know, occasionally there's the harebrained scheme that pops up, but there's no doubt that the public consciousness is getting a taste of VR. As this improves, when VR headsets become like toasters, you know, every home has one, you might not use it every day, then people may expect to use it in their healthcare. You know, some overwrought things, you know, some cautionary tales, some oddball things, naysayers, you know, if somebody said rock is dead back in 1969, we know how that turned out. I think there was an article in Engadget, VR is dead, you know, okay, you know, clickbait. We know that this is not going to fold up its tent and go away. It's not like 1996 anymore. You know, and people mentioned the Gartner Group. You know, for 20 years, every year the Gartner Group's tech thing would come out. I'd look at it and say, ooh, is VR going to move out of the trough of disillusionment? And it was still there. And finally, in 2017, it's starting to move up the slope of enlightenment. So that's positive. You know, of course, you know, all kinds of projections about, the value of this. We know healthcare comes in second after entertainment in terms of predicted market share. Neuroscientists get it, the ultimate Skinner box, controlled stimulus environment. Clinicians get it. This is a study where VR came in 4th out of 45 options rated by master clinicians, therapists, in terms of what's going to change in the next 10 years. Virtually Better, they started up in '95. They're still around. They were the only game in town. Well, this is a short list of more companies in the last year or two than in the previous 20 popping up in this space. So a lot of future events. We have, events that have been going on for many years. This one here in September, it's been going on since 1996. So, a real solid community. People have been around for a while developing this stuff. I highly encourage it. I have flyers for that conference. And to close, there's issues about maybe kids shouldn't use VR that much. When I got my gear, the first time I flew back to Connecticut and gave it to my niece and nephews to try, I had to wrestle it out of their hands, But the night before this was taken, I got in at like 3 in the morning. My flight was delayed, and my mom was waiting up for me. And I go, Mom, you got to try this. So this is my 83-year-old mom at the time in her first VR experience.
It's so real. My God, it looks like my backyard, my yard with the snow. Oh, Lord in heaven. How they ever can create this. You know what? I'm hanging onto the sink because I'm afraid I'm going to fall down the cliff. Yeah, honest to God. You feel like, if you step off, you're going to fall right in there. Holy mackerel.
And finally,
if you're watching this, please fund my son's research so that he can take care of me in my old age.
so thank you very much. Sorry I went over, Brennan. I promised I wouldn't, but